Right here.
The atrium.
Okay, right here. Where is that? What
The right atrium.
Right side of the
On
Is
the
it
right.
beneath the left nipple?
No.
Is it in the mid-sternum?
No.
Is it below the clavicle?
Yes.
So see how she's asking these questions regarding heart? Let's see. Which of these events does the P wave represent? What does the P wave represent? Atrial depolarization and also what? SA node firing. So what would you look for in that answer? Either the SA node firing or atrial depolarization, right? Very good. Patient asks, where is the sinus node located? Which of these responses by the nurse would be correct? So we call them the nodes, the sinus nodes, right? And then it's the, what does the SA node stand for? What is the S? Sinus atrial. And then the atrial ventricular. So the sinus atrial node is where? On the right atrium. So it says that you would say to the patient, right atrium, left atrium, right ventricle, or left ventricle? Right atrium. A nurse caring for a patient develops sinus tachycardia. Which of these actions should the nurse take first? So sinus tachycardia means what is the patient feeling? Very rapid heartbeat, shortness of breath. What are you going to do?
Oxygen.
Put oxygen on, and what else? Oh, I know what she wants you to do. And there's a Valsalva movie we can do to get them to try and not have a sinus tachycardia. So you ask them to bear down like they're having a bowel movement for a second. And so you can ask them to do the valve, if they are allowed to do the bear down like they're having a BM, but you're not allowed to do the carotid artery rub. So you can do the, well, while you see them go sinus tac, say to them, can you just bear down for a minute like you're going to push for a second? Have them bear down for a second, and then you see their heart rate stop for a second and start. It's very quick. If it goes back into regular, then you don't need to get anybody. And you just print out the strip and put it in their chart that they had a moment of sinus tachycardia. But if that doesn't work, then you'd have to go farther and get your RN and all that. So you would say to this person, a nurse is caring for a patient who develops sinus tachycardia. Which of these actions first? Would you inform the registered nurse promptly? No, because you can't hold the patient's side. Would you have the patient cough forcefully?
No.
Would you recheck vital signs in an hour?
No.
Would you turn the patient to the left side? Okay, the second one. When you cough, you're doing what?
Oh, yes.
Just cough yourself and you see how much pressure you put on it. The patient has sustained ventricular tachycardia. The nurse recognizes it can progress to which of these dysrhythmias? So we're talking ventricular tachycardia. We looked at it. And I said ventricular tachycardia can always go into what? AFib. And then what? Okay, here it is. Why do you need to know these numbers? Which of these is the normal PR interval? And it gives you a choice of numbers. Which of these waves is the second positive wave in a normal cardiac cycle? So you gotta know that. Let's see. What is a premature ventricular contraction? We didn't talk about that, but what that would be is you literally are watching the heart rate, okay, and you look sinus. So you see the PQRS, PQRS, and then all of a sudden you'd see a QRS without a P. That's a premature ventricular contraction. It doesn't have a P wave and it's not followed by a T wave. It's just a QRS by itself. Okay, so that's a premature ventricular contraction. And what causes them? What can make you feel a little bit of a heartbeat skip? Name some products.
Cigarettes.
Cigarettes, caffeine,
If you see a crush.
sinus pills, and your choice on here is
Caffeine.
No dose. 5 orange juice.
oh, here's a good one. Did she teach you guys about pacemakers?
No.
Okay, so So the nurse is discharging a patient with a pacemaker, and you've given them instructions, and one of the instructions you have to give is symptoms and signs of artificial pacemaker malfunction. So would it be
Glitch.
tingling to chest area, dizziness during activity, pain radiating down the arm, or tenderness beneath the skin, and it would be dizziness with activity? Because what that means is that you're having some bradycardia, and that means the pacer's not pacing right. Okay, so if they get dizzy with activity and they have a pacemaker, they need to get it checked. Which of these waves represents ventricular depolarization?
QRS.
Ventricular depolarization.
QRS.
The QRS.
QRS
The T
complex.
wave represents what?
The
T wave
repolarization.
represents
The absolute
refraction.
Absolutely.
It is a repolarization of both of them, but of the atrium and ventricle, but it's called absolute refraction of the T wave.
And the atriums are also repolarizing?
Yes. Everything's building up for the next beat.
I always thought that atrial, you don't see an atrial repolarization, but atrial restaurants has max.
It hiddens it inside there, yes.
The T would just be the ventricular.
I was taught that it's everything. That's why it's called absolute refraction, because it's absolutely setting everything up. So yours makes sense too, though. Okay, Lipitor has been prescribed to a client with elevated cholesterol. The nurse collects a healthy history from the client, knowing that the medication is contraindicated in which of the following? When is Lipitor what is Lipitor?
For cholesterol.
For cholesterol. And what about Lipitor that it is contraindicated? Do you have your drug sheet with you I gave you? Yes, ma'am.
I got it.
Yes, but there's an illness that a person can't have and if they take Lipitor.
Liver? I'm just guessing.
Now, why would you guess that?
I don't know, because I'm tired.
No, now keep going, because you're right.
There was something that
If they have
the lowering
cirrhosis,
thing.
they cannot have Lipitor because it's digested
You got
by
it.
the enzyme in the liver, and it'll cause problems in the bloodstream.
Good job. Good job.
Okay, what does the word manifestation?
Lipitor is contraindicated for liver cirrhosis.
Right? So, a patient who has ventricular fibrillation, which of the manifestations would the nurse find on the assessment? So ventricular fibrillation, the person's not even, they are unconscious, that's right. Would you have dyspnea? Would you have pinpoint pupils, absent peripheral pulses, calculated refill less than 3 seconds? And if you have the ventricular fib, you guys, the ventricles are just going like this, so they're really not pushing blood through circulation, so you have absent what? Absent pulses. And that's what confuses a lot of people. They go, well, there's a rhythm up there, but I don't feel any pulses. Well, that's because you have V-fib or V-tap. Okay? Which of the waves is the first? Oh, she said that already. An electrical impulse that originates in the sinus node travels there to which of these areas of the heart? So, yeah, that's exactly right. But that's worded weird. Can you repeat that? Okay, an electrical impulse that originates in the sinus node, which is the SA node, travels from there to which of these areas of the heart? So just keep your mind that sinus node is the atrial, sinus atrial node. Starts with the SA node, the AV node, the bundle of the node. Okay. Oh, that one's different. Which of these is the initial electrical treatment for ventricular fibrillation? It always has to be synchronized. This is for, this question is asking you, which of these is the initial treatment for ventricular CPR? No, you don't do CPR, ventricular fibrillation, you don't do CPR first. You have to get the heart stopped before you can do CPR. And so you would synchronize it and cardiovert at the lowest amount of joules first and go up. So the lowest amount of joules, do any of you know that level yet? The lowest amount is 200, and then it goes up to 360. So the doctor would always have you set the defibrillator at 200, but wait for his call, because he has to try and figure out when to defibrillate. The defib is very hard. Okay? Let's see. Oh, if the patient has a history of a implanted pacemaker, can they have an MRI?
No.
What if they absolutely have to have an MRI? MRI and CT are different.
Yeah, but if they have a.
You know, we came across that, and what the doctor said is he'd have to take the defibrillator out and put the patient on an external pacer until the MRI was finished. And they have external pacers that are acceptable to the MRI machines now, as well as oxygen tanks. If you don't have a long enough extension of the oxygen tank, don't take the oxygen tank near the MRI. At Children's Hospital in LA, a little boy was 8 years old, cystic fibrosis, went in for an MRI, and he was on oxygen, and the nurse thought she had it far enough away. And as the child laid down, the oxygen tank came in like a missile and decapitated him, because the MRI machine magnet brought it right in. So make sure you're aware, does your patient have metal fragments anywhere? Because the magnet will pull them right out of their skin. If the patient has a pacemaker, they can't have an MRI. If it's life-threatening, then the doctor has to remove the pacemaker and put him on one that's acceptable for the MRI machine, and it's external. So the patient with a pacemaker cannot have an MRI unless you have that doctor, again, that is insistent. An electrical impulse, oh, we said that already. Patient reports having palpitations, and you find PVCs. Which of these manifestations would be present when the patient's having PVCs? Would they be lightheaded, headache, confusion, or tingling in extremities? They might feel lightheaded, definitely, because the PVCs make them a little bit dizzy. So, yeah. People tend to feel their heartbeat, they get nervous. So, a PVC is usually felt by the patient. Okay, let's look at a rhythm, see how difficult it is. Okay, so she's not asking for, she's asking for the heart rate and the rhythm, but she's not asking for PR intervals or anything like that. And they look like our very basic rhythms, okay? There's nothing hard, even in these handouts she gave us, there's nothing like that. Okay, and then she has your medications are drops per minute. What happens to their vascular system with hypertension? What diets do they need to take in order to assist themselves in I would say the proper nutrition needs of a person who's got hypertension already? If they have hypertension already, they have a lot of vascular changes. When you have hypertension, you have vascular changes. And we have to really assist our patients to understand that a lot of those vascular changes are not reversible. And so disease processes start, but we can cause the onset of a stroke and such to be farther away by following diets and exercise and changing modifiable risks, correct? Modifiable risks, again, you guys, are? Smoking, exercise, obesity, what else? Drug use, what else?
Stress.
Alcohol use, stress. What about stress? This is really hard on patients. When we say you've got to modify your stress, let's see if this is the one we want to start with. When we say you've got to modify your stress, patients really have a hard time. They have a great need to tell you about all their stress, but they really have no idea how to relieve their stress. And as nurses, we're the ones that have to tell them how to adjust their lifestyles to relieve stress. So let's get down to that PowerPoint here.
this already. Okay, so it starts right here. Okay, so basically, the etiology, what does the word etiology mean?
The cost.
The cause. What do you think is the cause of,
Make it bigger, please.
what do you think is the generalized cause of hypertension? How does hypertension start in a person? Can they be born with hypertension? Yeah, it's a congenital malformation, right? Congenital malformation means what? Something went wrong in neurodevelopment with their cardiovascular system or their pulmonary system, and it has caused them to be born with high blood pressure. We're not talking about those people that are born with high blood pressure. We're talking about you and I who are sitting here living our lives and go to our doctor appointment and the doctor says, ooh, you got high blood pressure. The doctor wants you to usually come back 3 weeks or every week for 3 weeks, measuring your blood pressure at the same time after the same activities have taken place, so that they can see if this is a true onset of high blood pressure or not. So when we talk about blood pressure being high, it means that your blood pressure, your systolic blood pressure, has to be measured, attainable, and sustained or elevated at this level higher than 120 or 10 to 20 millimeters of mercury higher than the book normal. So the book normal is 120, right? So if we add 10 to 20 millimeters of mercury to that, we get 130 to 140. If somebody sustains 130 to 140 for over a length of time, they are destined to have systolic hypertension so far. Okay? Systolic hypertension, again, is the person's inability to bring their systolic number back down to the book normal of 120 or below. So at 130, they're in the mild onset of hypertension. 140, they're in the first phase of hypertension. If they sustain 140 over weeks of a time, then they are primary hypertensive patients. They have primary high blood pressure. Primary high blood pressure, again, is the ability to, it's not that we want to sustain that, but it's the lack of ability is the better word, of your vascular system being able to bring your blood pressure back down to a normal level. So we have to figure out, why is that person's blood pressure suddenly elevated? So the first few questions you ask a patient is about their stress in their life. And they're saying, I don't have any stress. And you know, you can't say, yes you do, everybody has stress. Now tell me about your stress. Because a lot of people don't understand. If you ask my husband, do you have stress in your life? He'll say, no. No, but we do. We have a daughter living with us, with her husband, 2 grandchildren. We have 2 more dogs than we want, so we have a total of 3 dogs. We have a renter who pays their rent late, but pays it. We have, you know, our own health issues, our own bills, our own personal issues, and so we have stress in our life. And that stress is representative on my husband by his high blood pressure. And so his blood pressure went literally over a week's time from about 110 over 70 to where he maintains it now, 150 over 90. And he's on the highest dose of hypertensive medication. He is a primary high blood pressure because his mother had high blood pressure. So it was destined to happen, but if he had followed the proper diet and exercise pattern, he probably wouldn't have it right now. And so because he has increased in weight, which is what a lot of us do with stress, we gain weight because we munch. Some of us find food, especially carbohydrates, very satisfying when we're stressed out. Some find beer. Beer is very fattening as well. You know, whatever we find is the wrong thing usually. And what we need to do is go for a walk and try and figure out how to decrease our stress. Instead, I'd rather eat a bag of chocolate chip cookies. How about it? How about making a fresh batch of brownies, you know? Things like that. And being in the field doesn't make it easy. I'm still human, okay? So when a person sustains an elevated systolic blood pressure, elevated number, above 10 to 20 millimeters mercury higher than 120, they start into that phase of hypertension. And there's 4 phases. First one is the onset phase, and it is it could go down, meaning that the patient could come in and have 140/110, and the doctor says, "Wow, your blood pressure's elevated today." But what we haven't asked is what happened today to that patient. The patient told his boss in the morning he had to leave early for his appointment. But when it came time to leave for his appointment, his boss scheduled a meeting that was life or death for the company. And the patient has to miss the meeting because the appointment is so important to him. At least he's following up with his MD. Usually they don't, right? They usually miss the appointment. So we applaud him for showing up for his appointment. Now let's see the following week if something similar happens and what his blood pressure looks like. So he comes in the following week and his blood pressure is 150/98. Has it improved? No, it hasn't improved. And so we ask him again, what happened at work? He says, I'm having a great week. Nothing like last week. Did my blood pressure improve? And we say, no, not yet. He says, do I have high blood pressure? We want to tell him, right now your blood pressure's showing high numbers, but we won't make an opinion of it or a decision of it until the next 2 blood pressures have been taken, a total of 3, okay? And they're a week apart. Doing the same activity, waking up, getting your cup of coffee, having your cigarette, drinking your beer, whatever you do, normally you need to still do during those 3 weeks. Why? To confirm that your body has high blood pressure. If all of a sudden he changes his routine, we're not going to get a true reading because he might bring it down by changing his routine and say to himself, wow, okay, so if I don't drink coffee and smoke a cigarette every day, then my blood pressure will be normal. And then he's going to have those days where he drinks coffee and smokes a cigarette and he could have a stroke because we didn't detect it truthfully, okay? So they come in 3 times. If their systolic number remains 10 to 20 millimeters of mercury, do you know what I'm saying when I say 10 to 20 millimeters of mercury? Okay, the actual reading, the sphygmomograph thing on the wall that measures your blood pressure in mercury, okay? That's a mercury column that rises and falls when it's on the wall, and you do it manually. That is called millimeters of mercury measurement. So if you get 90/60, you have a 90 millimeter mercury measurement on the systolic. And you have a 60 millimeter mercury measurement on the diastolic. Okay, do you understand now? So it's just a term used because they used to always measure blood pressure manually with mercury. So now we have automated cuffs. They're not always sufficient. If they get bumped and dragged around the clinic a lot, they internally become unbalanced and they read people either too high or too low. If you have the wrong cuff size on a patient, if you put too large of a cuff, you can get a low blood pressure when they're really high. If you put too small of a cuff, you can get a high blood pressure when they're really low. So there's factors you have to employ to ensure that you're getting the right blood pressure of that patient. So you have to make sure the cuff fits them properly. You have to make sure it's in the appropriate location. You have to make sure that your equipment is balanced and going to be reading correctly. Whether it's a automated or manual, you have to make sure it's balanced. Now manual, the only way you can make sure it's balanced is really and truly, we used to test it on each other before patients came in at Kaiser. And then we used to have a guy that came from the equipment oversight, and he literally knew how to really test it. But in the morning, we'd get 3 of us together before patients came in, and we'd take each other's blood pressures on these cuffs because we hauled those things all around and banged them into walls and tipped them over and everything, but we needed to make sure they were still working right. And if it came out weird, we immediately called engineering, tagged the machine, and got a different machine for the day. Because you don't want to chance it. This is people's blood pressure, okay? When we say 10 to 20, we're looking at that measurement of the book normal always. We start with the book normal is 120, correct, for systolic? And we're adding 10 to the 120, or we're adding 20 to the 120. So whether it comes out 130 or 140, in those numerical numbers, 130, 135, 140, the patient is high. So we're saying 10 to 20 means you can get anywhere from 10 number increase to 20 number increase, and that means that they're running high, okay? Same with the diastolic, 10 to 20 millimeter mercury higher than normal, and they're running high. We do it 3 times. We're looking at that blood pressure, we're looking at their habits, and we're looking to find a normal range on this person. On the 3rd time, they usually see the doctor, and the doctor counsels them and tells them, here is the information you need to follow in order to assist yourself. And the information to the patients feels like this book. And they don't read it, do they? So who's the person that has to educate the patient on hypertension? It's us, the LVNs, not the medical assistants or the CNAs. And so you need to understand what you're doing to educate them. So what is one thing with diet that we would want to introduce to the patient if they already didn't know? What kind of a diet change? Okay, why do we go right to low sodium? How come we all know that? What's with sodium that we want everybody to decrease?
Water retention.
Water retention, very good. And why do we have water retention is because if you had the chance of taking chemistry back then and physiology, there are these gateways in cells, and they have these sodium gates and these calcium gates, and they have these other gateways that all exchange ions. Ions are the molecules that help generate a current for that cell to stay alive. If the sodium is increased in the interstitial, where's our interstitial? Outside of the cell, okay? So if the sodium's increased in the interstitial fluid, the cell's going to become dehydrated inside of it, and it's going to want to bring that sodium in to fill it with some water, and there's going to be a sodium exchange in the cells and stuff, and you're going to be retaining fluid both at a cellular level and interstitial level. First it'll be a cellular level, and then as your cells and vascular system can't hold up anymore, it becomes interstitial. Some people have primary edema that never goes away, but it gets worse during the day, but it can get better, so we educate them on that. So the first thing we tell them is low sodium. Are we going to tell them numbers? You can only have 5 milligrams. What would you do if somebody said that to you? You'd be like, well, how do I count it? Is that 5 little grains of salt or what, right? So we want to teach them, look at the things you have around the home that you generally take into your mouth. Do you take in Pepsi and Coca-Cola and Dr. Pepper? Which one of those has the highest amount of sodium? Does anybody know? Dr. Pepper. And then Mountain Dew has the highest of all of them. And so you have to talk to them about their soda drinking habits. What about caffeine? Can they have caffeine?
Yes.
What if they have caffeine every single morning? Do they have to stop right now?
No.
We have to taper them off, right? What'll happen if they just stop right now?
Headaches.
Headache. So how can we educate the patient on tapering down on caffeine? Well, today he's going to buy his regular cup of coffee from Starbucks. Tomorrow he's going to ask for half of that cup of coffee or 3/4 of that cup of coffee, and then add something else to it to dilute it. And then every day he's going to need to go from a venti down all the way to a grande, and then even smaller without extra shots. And we had a patient that literally had 3 extra shots added to his drink every day. So we taught him, this week, tomorrow you have your 3 extra shots, the next day, and for that whole week after you only have 2 extra shots. And then for the whole week after that you only have 1 extra shot. Because if you told them decrease it over 1 week's time from 3 to 1, he wouldn't be successful. What does cigarette smoking do to blood pressure? Does it? Cigarette smoking is a vasoconstrictor. Nicotine causes vasoconstriction. So when people are going, ooh, I'm freezing, I gotta go outside and get a cigarette, and they stand outside with goosebumps. Can you go, are you warmer? Mm-hmm. They're not warmer, are they? They have massive vasoconstriction, but the nicotine filling causes them to feel as though they're warmer, but they're not. they're actually getting colder. What they're doing to their blood pressure is increasing it because of the nicotine being a vasoconstrictor. Vaso meaning vascular, constrictor meaning veins are all getting smaller. Okay? And so vasoconstriction increases blood pressure. Essential primary hypertension is diagnosed 90% to 95% of the time in people who have high blood pressure. 95% of them is primary high blood pressure, which means you got it from your first parent, mother or father, and you now have the onset. You have primary hypertension, and it's not caused by kidney problems yet. It doesn't involve the liver, it doesn't involve the esophagus, anything like that. It is primary hypertension brought on by your inheritance or your genetic and your diet and stress. Could you have held off the onset of primary hypertension? Sure, if you watched your diet and maintained your stress levels. So primary hypertension is a genetic problem with a person. That's predisposed to it, and it causes high blood pressure. And we have to teach them diet and exercise, and a lot of times we can get primary hypertension to actually become regular blood pressure again through diet and exercise, and not affect the kidneys or heart or anything, and hold off the hypertensive episodes of possible stroke and stuff by simply changing their awareness of stress, diet, and exercise. Secondary hypertension is attributed to an identifiable medical diagnosis. So what would be a medical diagnosis that causes high blood pressure? Can anybody guess? Coronary artery disease, definitely. By causing buildup, it is a implanted constrictive process, right? There's implanted fats and cholesterol inside the veins, so it constricts, it narrows the orifices for the blood to flow by, so it causes constriction that way. What else would be a secondary diagnosis that would give somebody high blood pressure? Head trauma. Ooh, those are big ones, especially nowadays, and that will be a lot on your NCLEX. Head trauma is a big talk today. Why? Because we have our war veterans that are surviving head traumas that they wouldn't have survived 12, 14, 15 years ago. Now with medical technology, they're surviving, and we now have to figure out what do we do with our soldiers that have traumatic brain trauma, right? Most of them end up divorced. We've got to have a place for them to be respected and treated. Head trauma. What else is another diagnosis that could cause secondary hypertensive? Kidney failure. Your kidneys are the primary tool that regulates your blood pressure. Remember learning about the kidneys, about the ACH or ADH and all those things that circulate through the kidney. Eventually, the kidneys absorb the waste products and the extra fluid and release them through the urine, and thus causing less volume and assisting in the control of blood pressure, correct? You guys, it's 11:30, you're falling asleep, go eat lunch, be back no later than 12:30, please.
When do we get our test scores?
Before the end of the day.
This test or you talking about the one from yesterday?
No, the one from yesterday. Sorry, I have a hard time. You started hearing, so when you walked up talking, I didn't catch it.
I do all the time. Is it the math from today? Are you going to add that in?
Yeah, I'll talk about that after, because the math from yesterday too, I didn't add it. Because I don't know what she's going to do. 64, so about 60.
Okay.
So,
So you can pass that part, and then she can come back and then.
yeah, she can let you guys know on that part. She has to let me know too, because like, what is she gonna do? She's gonna pick people that have 68 columns, and then figure there's only 64. Did you get the website?
No.
You didn't get the YouTube website?
No.
So you want to go to YouTube, type in YouTube, and when you're on YouTube, type IV calculations, and it comes up with lots of them. There's a woman that looks kind of Hispanic, and long black hair. Type in IV calculations, she goes through the 3 basic formulas you need to know.
Okay, okay.
And I don't know if he wants to say anything, so. Oh, my God.
Somebody's computer or voice thing is up here still.
Jason, see for Can you get that?
Mercury difference in a systolic or diastolic. Now we need to know what are their symptoms going to be. And not everybody will be classical. Hypertension, stroke is the leading cause of silent deaths. African Americans drop dead from hypertensive crisis without even realizing they had hypertension. And so what we need to do is get the word out there that everybody should be checking their blood pressure and monitoring their background, knowing their genetic predisposition, monitoring their diet and risks that cause high blood pressure. And some of the symptoms they might have is headache. And the headache is a headache that doesn't go away. They take Motrin, they take Tylenol, they take Benadryl, they take sinus pills. They go to the doctor, get narcotics, and this headache just does not go away. It's time to have a kidney function test to see if your kidneys are functioning right, because everybody's body, it doesn't matter what race you come from, if your kidneys are malfunctioning, you are for sure going to have a cardiovasculatory system problem, because the kidneys are the main controller of blood pressure. With the angiotensin and the renin phases of the kidneys, these are products that the kidneys produce. Those products help maintain and control blood pressure. So if your kidney function is not well, then your blood pressure is going to be high. So they might have a headache and blurred vision. First thing you always want to ask somebody who's had a headache and now has blurred vision is, do you have any problems with your eyesight? When's the last time you had your eyes checked? Because a simple prescription of eyeglasses could solve both problems. So you right away don't want to say to Auntie, since you get out of school today with this knowledge and she comes and tells you, I've had this headache and blurred vision. You don't want to go, oh my God, you're having a stroke, let's get to the hospital. You want to assess the entire person. Okay, have you had visual changes? When's the last time you had your eyes checked? Are you taking any vitamin, minerals, and herbs? Herbs are a big thing in society. People do not understand that herbs are medications. All our medications that we take by prescription are developed from plants. And once we understand how to mimic the chemical structure of a plant, we're able to mass produce those medications. So you have to understand, if people are on herbs, we have to start educating them. Herbs can counteract medications. Herbs can conflict with the kidney function. Herbs can raise blood pressure. Herbs can give you headaches, blurred vision. Herbs can kill you if taken with the wrong prescriptive medicine. So a lot of people don't understand that. They think because it's herbs, it's natural, it's not going to harm you. It's very harmful when combined with medications. So you want to take a good history when they have headache and blurred vision. Epitaxis, what is that? Nose bleeding. This is really common, and a lot of people get rushed to the hospital with a nosebleed and the family's freaked out. Oh, they got high blood pressure. Well, let's do our common evaluation. It's dry outside. It's very dry. Your nose is going to be dry. Are you having a nosebleed because of the dry weather? You know, when people turn their heaters on in their house when it starts getting cold, we get a lot of nosebleeds in the ER. People don't understand. My nose is bleeding. First thing we ask is, did you turn your heater on at home recently? Well, yeah, we just turned it on a week ago. Well, it's probably too dry in your house. You need to add a humidifier, but we check everything else. So epitaxis is another problem. Angina is a big one. Usually when a person has angina, we check their blood pressure and it tends to be a little bit elevated. And we always do an analysis on them about stress. We ask them what their daily routine is. How are things at home? You know, did you just get laid off from a job? Are you part of that part of society that is losing your home and lost your job and all of that? Because that is a horrible situation and causes a lot of people to have hypertension, crisis, chest pain, angina, all of these things. Angina is that aching pain in the heart that doesn't get better until they rest, right? It gets better with rest, and sometimes while they're resting, they have to utilize nitro. How many times? 3 times, 5 minutes apart, a total of 15-minute period. If your pain is still there, you call the doctor and you get a ride to the hospital, because that means that the nitro didn't work, so we've got to get your heart muscle relaxed. We can't have you continuously in pain because it causes damage to those little muscle fibers in the heart. Medical management interventions, those are our nursing things we can do without a doctor's order. So when there's a question asking you what is the nurse's first priority, and you're looking at your choices, think, can I do this without a doctor's order? Example, if you notice your patient's toenails are unsightly long, can you cut them without a doctor's order in the hospital?
No.
No. If you notice your patient has high blood pressure, can you go ahead and go get your other patient's type of medication and give it to? No. So what can the nurse do when she evaluates a patient with these types of symptoms and discovers high blood pressure? Now we have to focus, what are we going to do? Well, one of the things we'd like to do is first start off with relaxation. We really would like to teach people about themselves, about their stress, how it affects them, because not everybody likes medications and not everybody takes them like they should. So if we can get people understanding that if we manage our stress, our diet, and our activity levels in a good way, we can probably get our blood pressure down to a semi-normal range and alter the onset of a hypertensive problem by just monitoring and managing our stress, our diet, our exercise, our conversations with people. How we let people affect us is a big thing. A lot of people say nobody bothers them, but internally they're wound so tight when certain people come around them. You've got to learn how to not do that. You've got to learn how to stay relaxed when you're having conversations with people you don't like. You've got to. And when you guys become LVNs and you work with doctors, you're going to think it's all great when you get your first job, but when you finally get your foot in that doctor's office and start working with that doctor and you see him throw the autoclave down the hallway because somebody didn't make his appointment right, you're going to have to learn to deal with his stress or quit. And quitting's not that easy, is it? We tell people, well, quit your job if it's stressful. Well, what do they do next? It's not like the 80s. You can't quit today and have a job tomorrow. It is a big process now. So some of the pharmacological managements we want to offer patients once we can't handle their hypertension with stress control, relaxation, and diet, we start the pharmacological. These are the medications that have to have a prescription. They're the antihypertensive medicines. They're the diuretics. Now, what are antihypertensive medicines? We have 4 classes. Can you name the 4 classes? No? We have beta blockers. Does that sound familiar? We have calcium channel blockers. What else do we have? We have ARBs, or ARBS, and we have ACE inhibitors, right? And then we have our other class, we call it, of things that work to help decrease blood pressure, which are amazingly some of our antidepressant medications. If we can get their mood stabilized when we notice that it's a psychological problem, if they're too wound up and we can work on them with a mood stabilizer, we can actually control their blood pressure. So antihypertensive medicine. So how does the doctor say, you get ACE, you get ARBs, you get beta, and you get calcium? How do they know who gets what?
Levels in the body.
Depends upon the symptoms.
Depends upon the symptoms, their race, and their age. And the reason why we say race is because up here, see, I said, let's see, where did I write it? Yep, it's right there. Is because we know that some persons, some races do not do well on these types of medications. And so you need to know the side effects of thiazine diuretic, what happens with strep throat untreated, What is a hypertensive crisis? What happens with bleeding gums and the person's on heparin, drips, and Coumadin? What should the nurse do? This is really important to understand because in your book it tells you on this page right here, it tells you which persons can't have which medications. And the reason why they can't have these medications is because their body physiologically doesn't do well on these meds. And it doesn't matter sometimes if they're half white and half black. Black persons, as they call it in the book, in your choice of answers, it's African Americans. But in our book, it tells us they cannot have ACE inhibitors or beta blockers. And so we cannot prescribe to a African American person ACE inhibitors or beta blockers because they're more damaging to them than they're good, okay? We also wouldn't want to prescribe any kinds of diuretics or long-acting calcium channel blockers to older adults who have had an MI. So we have to know these things. So the doctor has a lot on his shoulders when he has to prescribe medication. He has to remember what race can have this type of medication. What will happen if I accidentally make a mistake, forget about the race and give it to them? Well, if you give African Americans ACE inhibitors or beta blockers, they tend to go into kidney failure. And why? We don't know. But physiologically, they don't do well on it, so we try not to give African American ACE inhibitors or beta blockers. And that's something as a nurse you always have to remember. You should always know your side effects of your medications because the first thing the patient's going to ask you is, how am I going to feel if I'm on these? Now, just off the top of your head, doesn't matter what class of medication you're on. If you're on antihypertensive medications and you're a male, what is one side effect you're going to develop? Erectile dysfunction. It might not start right away. It might be months to a year. And then all of a sudden the man realizes that he can't maintain an erection during sexual intercourse. And psychologically, he's damaged immediately. The wife or the other significant other really says it's okay. But the man really, they'll be the first one at the door. They won't let their wife make that appointment. All other appointments, we as women have to make for men. They will not call the doctor and go to the doctor for anything unless it concerns their genitalia. When their genitalia doesn't work the way they want it to, they're the first persons at the door on the phone of the doctor. And so one thing we always want to educate the patients with when they're male patients and they're being prescribed antihypertensive medications, we want to tell them, since you're starting a new medication for control of your blood pressure, you always want to get up from a laying position slowly. And as you get up and you feel dizzy, sit and dangle at the side of the bed. If you're at work, working at the computer, and you're going to stand up to go talk to somebody, they need to turn away from the computer, stretch their legs out in their chair, turn their head a little bit, and then stand up for a moment, stay standing there for a moment. Because people drop at work all the time because they don't realize that even in a sitting position for a couple hours, going to a standing position can cause that hypotension fainting spell as well. And so you want to tell them to make sure that they monitor themselves for signs and symptoms of low blood pressure, which are dizziness, inability to stand up, inability to actually, they're going to feel their heart bounding real hard, and they're going to feel as if they are going to get a headache when their hypertensive medicine is giving them a side effect. They don't get the headache. They just, a lot of patients say they feel like they're going to have a headache. Have you ever had that feeling? You got this dull ache in your head? Until they keep up their fluid levels and get balanced on their medicines, and usually, just like antipsychotic medicines, it takes doctors a lot of playing with dosages and changing medication types to assist the patient to have the right medicine for that person. Okay? So you want to tell them to get up from a laying position carefully, make sure they dangle, watch for signs and symptoms of dizziness or low blood pressure, watch for chest pain. And then you also want to tell them to be careful that they watch their diet. We want to maintain them. If they're on calcium channel blockers, can they have a lot of calcium? Can they eat Tums?
No.
No, they can't, because we are putting them on a calcium channel blocker, which is going to block the outburst of calcium into the bloodstream for a little bit longer. And so if you're putting a bunch of calcium in the bloodstream through oral intake and then the calcium's released, you're going to have arteriosclerosis, that is going to be a calcium deposits. You're going to have hardening of the arteries from the calcium. You're going to have a lot of side effects. And that's not a good thing. More calcium's not a good thing. Less calcium's not a good thing. Again, we have to find the balance. You have to know the diet limitations of the medication so that you can best educate the patient on them. The other thing that our questions want us to know about is the two types we talked about. Hypertension is the blood flow that is extremely, how do I say it? It is the blood flow in the arterioles that is putting extreme pressure on the walls of the arterioles, causing blood pressure. So if we naturally have pressure on the walls of our arterioles that is measurable for blood pressure, having them become constricted with that pressure still at that peak can cause arterial wall malformations. And the first arterial area or artery area that suffers the malformations, guess where that is? Your aorta. Now, when you have your aorta having problems, this is the main line in your body going from your heart, servicing down past your heart, down your femoral arteries to service your legs with oxygenated blood, and your lower half of your body, as well as it has branches off of it to feed all of your organs, okay? So if your aorta starts to have this bulging problem in it, it's prone to break, right? To rupture, because the aorta is not a artery that likes to have a bulge. It's formed the way it is. It doesn't want to be pliable. It will presume a position a little bit, and we measure that through a CT or ultrasound, and we'll tell the patient, we see your aorta bulging. It's a 3 centimeter bulge. Now that would scare me, but we don't surgically do anything until it's 6 centimeters or bigger. When it's 6 centimeters or bigger, we go in and do an aorta bypass and graft and repair, depending on what's happened to the aorta at the area. When they do that, they have to clip off the top of the aorta from having blood transfused through it, as well as below the bulge or rupture, so that they dissect this whole portion of the aorta or reinforce this portion. They can only have your body clamped off at both locations for less than 6 minutes. Why? You're not pushing blood through your lower, through your organs, or to your brain right now. Because you've got this clamped off and this clamped off, the patient is very susceptible to developing what? Blood clots, embolisms, everywhere, because nothing's circulating. So they start the clock immediately when they clamp this, and when they're adding the graft or adding the wrap, whatever they have to do, they have to do it in less than 6 minutes. And they unclamp it and they see how the perfusion is working. If it works with no leaks, then they're a success. Unfortunately, this aorta is prone to leak after it's been repaired. And so patients will complain of a really weird feeling of fluid gathering in their abdomen. And so you have to measure their girth, you have to palpitate all their pulse locations, and you also have to teach them the signs and symptoms of a rupture. Does anybody, have you had the talk of the abdominal aorta rupture repair yet? Have you had that conversation yet? Well, they all have the common effect, the common onset. the patient will complain of a stabbing feeling to their gut with a tearing away from their spine. And that is literally the aorta rupturing. And you want to get in there, you want to get it diagnosed and get them to OR immediately when they're having symptoms. If they're 3 centimeters and having those symptoms, the doctors will operate on them. But if they're 3 centimeters measured upon just an examination and they're not having any symptoms, they do not touch it. So once again, if there's 3 centimeters with symptoms of a stabbing gut pain and a tearing away from their back, the doctors will take them in and repair it or remove it and replace it, okay? If they're 3 centimeters and no complaints, you just happen to find this result upon thorough examination, then you don't do anything with it. And a lot of physicians and hospitals and doctors' offices are now putting in their 60-year-old or older pre-screening of the aorta on a yearly basis to get an ultrasound of the aorta, to monitor it, to make sure they don't have a rupture. Because do you all know that show that was Come and Knock on My Door? Okay. John Ritter, right? That's his name? Only 52 years old, was filming a series show when he was stricken with this stabbing gut pain and wrenching, pulling away from his spine. And his body's response to those symptoms was vomiting as well. And then he got the chills. So he walked across from the set to Paramount Motion Picture Hospital. And he was in the ER complaining of stabbing to his gut and a wrenching, tearing apart from his spine and vomiting. They misdiagnosed him. He sat in that bed for 6.5 hours before he was dead. And he could have been rushed to the OR and had his dissecting aorta repaired. I don't know if he would have survived, but at least we would have known what it was. And his family since sued because he had the classic signs, but with the vomiting adding, they said he had the flu. So they gave him morphine for the pain and Zofran for the vomiting, and the man didn't go to sleep and the pain didn't subside, so they increased the morphine. And by that time he's almost unconscious, so they think he's dehydrated, start an IV line. I mean, it just was a whole bunch of miscare for a very classical presentation. And so it's nurses that have to remember these presentations, these signs and symptoms, so we can initiate the thought in the doctor's head, hey doc, could this be his aorta? I heard one time that it causes this. Yeah, but he's vomiting. But that might be his body's response to pain. A lot of people vomit with pain. They pass out with pain. A lot of people do. So you have to understand what the arterial blood pressure is, which is the blood volume flowing through the arterial. It's the pressure put on the arterial walls. And what happens to the arterial blood pressure if the arteries are constricted, whether it's through onset of hypertension or arteriosclerosis or some other problem that's causing those areas to constrict. You are now prone to developing a AAA, abdominal aorta aneurysm, and it has to be treated, okay? High blood pressure can be the sign or symptom early in the patient that is developing an aneurysm. Because the aorta is the main artery of blood, if it's beginning to bulge, the onset everywhere else vascular-wise could be high blood pressure. So when a person has a new onset of high blood pressure, it's not untypical for the doctor to order an ultrasound of the aorta to make sure it's not the cause. He'll also order a kidney function because, again, we need to make sure that your blood, urea, and nitrogen are not off, that your kidneys are functioning well, because they are the main controller of your blood pressures. The blood flow and peripheral play what role in blood pressure? Well, they play the major role in regulating blood pressure. If the blood flow peripherally is constricted, how is the blood pressure going to be read? In what range? If your peripheral vascular system is constricted, your blood pressure is going to be up. If your peripheral vascular system is relaxed, your blood pressure most likely will be normal. In the aging process, what happens to the walls of the vessels and the walls of the arteries? What happens? They lose elasticity. And so at first you see patients with really low blood pressure. And you're thinking, wow, this person's really low blood pressure and they're like 90 years old. And the doctor might put them on a cardiac medicine to increase the cardiac contractility to help bring up the output and help bring up the blood pressure. Hi. Hi.
We have a visit.
Hi. Good afternoon.
Hi.
I'm Pam.
From the Accreditation Agency.
You're Dr.
Morris.
Nice to meet you. These are my term 3 students. They're vocational nurses. And how can I assist you?
Let me just spend like a few minutes with them.
Sure. So you want me out of the room when you're
Sure.
talking to them? Sure.
Thank you.